Thank you very much, and welcome everyone to this afternoon's webinar. We're delighted to be working with the Christopher and Dana Reid Foundation and hope that the information we will be presenting will be useful to you. We will present for about an hour, and then we will take questions and answers for about half an hour. And after that time, if you have further questions, we'll be giving you a way to get in touch with us so that we can continue to be a resource for you in the future. I'm Judy Stein. I'm the Executive Director and an attorney. I founded the Center in 1986. And my colleague and Associate Director, Kathy Holt, is here, who is going to be presenting with me. We'll be talking about different topics of particular interest to people living with paralysis regarding Medicare and Medicare coverage. The Center was founded in 1986. We are a national organization and a leading advocate since 1986 for Medicare beneficiaries, people who are older and or have substantial disabilities and rely mostly on Medicare to access therapy, medical care, and other services they need to maintain or improve their condition in the healthcare and therapy arena. We do not represent providers, and our interests are solely in making sure that Medicare's promise and what it has in the law is actually and properly provided to the people who rely on the program for access to care. We're a nonprofit organization and a nonpartisan organization, and we provide education, advocacy, and assistance throughout the country. We've been working with the Christopher and Dana Reid Foundation for a number of years today, and are delighted and honored to be working with them today on this webinar. Our offices are headquartered in Washington, D.C. and Connecticut, and we have additional attorneys in California, Massachusetts, and New Jersey. This webinar is made possible by the Reid Foundation, and we thank the Foundation once again for partnering us on behalf of people living with paralysis. Today's agenda includes the following. We will be running through a great deal of information, but we think it's all of critical importance to people living with paralysis who rely on Medicare. And as I said, we will have a question and answer period at the end. First, I will give a quite brief overview of the Medicare program. We could do a webinar on each one of these topics, but we've determined that they're very important for you to know about, and so we are starting with this general overview. First of Medicare, then Kathy will talk about Medicare eligibility and enrollment. We'll talk about the pros and cons and how you might think about choosing to be part of what we call the traditional Medicare or a private Medicare Advantage plan. We'll talk about the facts and myths you may hear about Medicare and try and allay things that aren't true and focus in on things that are true about what may be available to you under the program. We'll spend a fairly good amount of time on the home health benefit and help you understand what coverage should be available under Medicare for home health care and how to go about trying to access it if it's not. And Kathy will also talk some about durable medical equipment, and that's equipment that you would generally use in your home and how you can access that. I'll talk some about outpatient therapy and how it's limited under Medicare to financial caps each year, and then we'll finish up with how to appeal if you've had problems with any of the benefits within the program that we've talked about or others that may affect your access to quality health care. So now I will talk about the first substantive area, an overview of Medicare. And let me begin by saying you should know that Medicare coverage is the same regardless of whether you qualify for coverage as a result of having obtained age 65 or as a result of having a substantial disability, which may be the case for many people living with paralysis, and we want to make sure that you understand that there's no difference in the benefit package available to the two different sets of folks who qualify for Medicare. Generally, Medicare is provided into Parts A, B, C, and D. Medicare Part A is known under the law as hospital insurance, and it covers inpatient hospital care, skilled nursing facility care, also known as a SNF, or in layman's term, a nursing home health care, and hospice care. The hospital coverage is the main expense for Medicare under the Part A benefit, and there is a deductible before hospital coverage kicks in for Medicare in the inpatient arena. And in 2017, you see here that's $1,316. Very often, people will have purchased a Medigap plan in order to pay for these deductibles. By the same token, there's a coinsurance if a person is in the hospital for more than 60 days, and that is $329 a day for days 61 through 90 in 2017. And again, very often, people would have a Medigap, also known as a Medicare supplement plan, that would pick up these copays if Medicare is covering the inpatient stay. Another important benefit under Medicare Part A that has a coinsurance responsibility is the skilled nursing facility, SNF, or nursing home benefit. The first 20 days are paid in full by Medicare if one qualifies, but after that, there is a daily coinsurance rate of $164.50, and that's, again, going to be coverable if Medicare pays by a person's Medigap or Medicare supplement insurance. Part B of Medicare is one of the other main substantive benefits under the Medicare program. It's known as medical insurance under the law, and it's voluntary. That is, a person can qualify and get Medicare Part A very often without paying a premium, but one has to decide whether you want to opt in or out of Part B. Part B covers physician services, some outpatient services such as outpatient therapy, some preventive services like mammograms, prostate cancer screening, and diabetes screening, and flu shots, and ambulance services, and durable medical equipment. Increasingly, it's important to know that Medicare Part B also pays for outpatient hospital services. And this is becoming increasingly important because very often people are in the hospital and they may stay a night or even 2 or 3 and be told that they're outpatients. Sometimes they're told they're outpatients on observation status. If that's the case, those hospital stays are paid for under Medicare Part B. There is a deductible before Medicare Part B pays for any of these services. It's $183 a year. And generally, it pays 80% of the charge, and there's a coinsurance of 20% for the rest of the Medicare-approved charge for the particular service. I do want to point out that it is likely that you should opt into Medicare Part B. If you don't, and you are later desirous of doing so, a person may have to pay a penalty of about 10% of the premium, and that can be very costly, of course. If you have coverage that is at least as strong as the Medicare Part B benefit, you wouldn't have to opt in, but you want to be very careful if you don't choose Medicare Part B. Let's go to the next slide. Medicare Part C is another name for the private plans that are called Medicare Advantage. The Medicare Advantage program is an alternative way to obtain the Parts A and B Medicare coverage, and this is through private plans. Each plan is provided by a different insurance company, although some insurance companies have a variety of plans, and you can choose at the end of each calendar year whether you want to be in the traditional Medicare program, which is the public program, or an alternative private Medicare Advantage plan. There are pros and cons, and Kathy will talk about some of them a little later in the program. But do know that you can make this choice annually. But if you do choose to be in a Medicare Advantage plan, you generally will not be able to go back to traditional Medicare until the next calendar year. In each program, the traditional Medicare program and in Medicare Advantage, the coverage standards should be the same, and the Medicare Advantage plan is required under law to provide at least the same benefits as traditional Medicare, and indeed to provide something more very often, such as some limited vision care, some health club benefits sometimes, some oral health care may be available in a traditional Medicare program. In the Medicare Advantage program, that is not available under traditional Medicare. You have to be very careful if you choose a Medicare Advantage plan. There are some limitations that Kathy will talk about. Finally, the fourth component of the Medicare program is the prescription drug benefit, which is available under Part D. This became effective in 2006. It provides some assistance with outpatient drugs. Again, these are all through private plans. If you're in traditional Medicare, you will need to choose a private Part D plan. And if you don't and decide later to do so when you need a prescription drug coverage, you may have to pay a penalty. So you want to make sure that if you choose not to get into a Medicare Part D plan when you're first eligible, that you have coverage through an employer or another means that it is at least as strong as the Medicare Part D prescription drug benefit would be. If it is, you should be okay, but if not, you will have to pay a penalty if you later decide to join. There is assistance with cost sharing for low-income beneficiaries under the Medicare Part D plan, and that's something you want to look into if you are of modest means. So that's a very quick run-through of the basics of Medicare, the four components, and generally what they pay, and the fact now you know that there is an option to be in the traditional program that's existed since 1965, or to opt into a private plan through Medicare Advantage. And now Kathy will talk about Medicare eligibility and enrollment. Kathy?
Thank you, Judy. So we're going to walk through a little bit about the Medicare eligibility and enrollment, and these are general provisions. There are many exceptions to them. So again, I'm going to give you an overview of the general provisions. So generally, there are, as Judy mentioned earlier, two ways to become eligible for Medicare. One is that you age into Medicare, you become age 65, and you had worked and paid into Social Security for the requisite time period, which is essentially, as Judy mentioned, Part A Medicare, what is largely the hospital benefit, is the requirement is 10 years having paid into the system, paid into the Social Security system or the Medicare system, paid taxes in your working career. So that's how people age into Medicare. The other alternative to receiving Medicare benefits and becoming eligible for them is when an individual has been determined under the Social Security or Railroad Retirement Act to meet the criteria for the program of Social Security disability insurance or railroad disability benefits. And that has to do with someone who is not able to perform regular and continuous work activity. So the determination of disability is made by the Social Security Administration, and they look at the work record of the individual to make sure that the individual has met that criteria. So once it's determined that the individual qualifies for the disability insurance benefits, and the next prong, if you will, to getting Medicare is to fulfill a 29-month waiting period. That would be a full 29 months, beginning from the Social Security disability determined onset date. And I would say on that it's typically a 5-month waiting period to receive cash benefits from Social Security, and then an additional 24 months from that time to qualify for Medicare. So that's where the 29 months comes from, the 5-month waiting period for cash benefits and then another 2-year waiting period. Now, there are exceptions, and if someone has Lou Gehrig's disease or end-stage renal disease, they may qualify sooner. Another group of individuals who would be able to qualify for benefits may not have paid into the Social Security system to the requisite amount for disability insurance could include disabled widowers and government workers who are not insured for Social Security disability insurance. And that would include teachers, firemen, policemen, different municipal workers who may have a different retirement system than Social Security, but did in their working career pay Medicare taxes. So that's the general information about eligibility. Now I want to turn to enrollment. And Judy spoke quite a bit about, or alluded to for certain, Medicare enrollment for individuals who initially decline Part B Medicare. So as Judy mentioned, you can sign up for Part A. It's for the vast majority of people, Part A doesn't require any additional premium, but Part B does. And sometimes people have current active employment through a spouse or a family member. There may be different reasons why people have other insurance. So you have to be careful. And again, this is a whole other webinar of what happens if you could have COBRA or you could have different types of insurance. But it's really important to check with Medicare if you're uncertain as to whether or not you should sign up and pay the Part B premium. They're not going to try to trick you to get more insurance than you need, but it's just for your peace of mind if you have a question as to whether or not you should decline Part B Medicare. Those who do decide to decline Part B Medicare, and I will say it's like any other insurance, they don't want you to sign up for it when you need it. So that's why they require everyone to have some kind of insurance, and then if you don't sign up for it in a timely manner, you will get a penalty. So a late enrollment may result in a penalty of 10% for every 12 months that an individual is not enrolled. So if you wait for 5 years to sign up for Part B when you were eligible 5 years ago, you're going to get a 50% penalty for waiting that 5 years. So as Judy said, it could become very costly. We had an individual here who called us, was 89 years old and had never signed up for Medicare. He aged into Medicare at 65, but boy, he had a big penalty because he was apparently a very healthy individual. So timely enrollment periods would be your initial enrollment period, and those are the 7-month period that surrounds either the 65th birthday or the notice of disability. And so Medicare will let individuals know if you're coming on to Medicare due to disability. You will get a notice that it's time to sign up for Part B Medicare. There's also something called the special enrollment period. You have up to 8 months following the separation of coverage based on current active employment. So again, if you are covered through a spouse or a family member who terminates their active employment, you have up to 8 months to enroll in Part B Medicare. I will caution you that while you have 8 months, up to 8 months to get Part B Medicare without a penalty, you only have 63 days for Part D Medicare to sign up before penalties start to ensue. So again, I'd go with the earliest date on that and make sure that you're making an inquiry anytime the circumstances surrounding other types of insurance will affect you. The general enrollment period for those who do miss their initial enrollment period would be January 1st through March 31st. That's at a time where if you missed your initial enrollment period and you don't have a special enrollment period, you have in those first 3 months of the year to sign up for Medicare, but the coverage doesn't begin until July 1st of that year. So we get a lot of calls from people here at the center for people who have missed their initial enrollment periods, and then they have to sometimes wait quite a few months before their coverage can actually kick in. I will also just a side note, if a late penalty is incurred, sorry for that. I don't know if you can see that, but we're getting something about an install of, oh dear, I'm going to release that. If a late penalty is incurred under age 65, it'll be vacated when the individual turns 65 and the individual gets another new initial enrollment period. So again, if you qualify for Medicare before you turn 65 and you have incurred an enrollment penalty, it will be eliminated when you turn 65. Okay, let's talk for just a little bit about choosing traditional Medicare or Medicare Advantage. And I'm providing here for you a decision checklist. Again, this is another full webinar to talk about how Medicare enrollees choose between traditional Medicare or a Medicare Advantage plan. And these are questions to ask to help you make your decision, but interpreting the answers is, again, a whole other webinar. So what you want to ask if you're trying to decide whether you should sign up for traditional Medicare or a Medicare Advantage plan is, do you qualify for payment assistance or have access to other coverage? That's going to affect what your choice might be. Which providers or facilities do you use or do you want to use? If you're under traditional Medicare, you have access to all providers who are Medicare certified. Under a Medicare Advantage plan, it's a managed care Medicare Advantage plan, you have to stay within the network of providers that have signed up with a particular Medicare Advantage plan. So you want to make sure that if you are going to specific facilities, you're seeing specific doctors or therapists, providers, you want to make sure if you're considering a Medicare Advantage plan that those individuals have signed up and are part of the network for the Medicare Advantage plan that you're considering. What medications are you taking? Again, make sure that whatever plans that you're looking at, particularly in a Medicare Advantage plan prescription drug program or in traditional Medicare, a Part D plan, what medications do you take, and are those medications included in that coverage? Is it acceptable to have your care choices directed? Some people feel that they want their own doctors to make the decisions about their care. In a Medicare Advantage plan, oftentimes what happens is the medical director of the Medicare Advantage plan or a utilization review committee of a Medicare Advantage plan will override what your doctor is ordering. So it's important to know if that is a very important item or issue for you. Do you travel outside your general home area? Again, Medicare Advantage plans are very limited in that they are networks of providers who are within certain counties or states, and if you are outside of that area, then you will only have coverage for emergency care. And so traveling is another issue that you should be considering. How important are annual maximum out-of-pocket costs? Medicare Advantage plans have maximum out-of-pocket costs. Traditional Medicare does not. If you have a Medicare supplement plan that will help with those additional deductibles and coinsurance and copays, then that lessens the risk or exposure that you would have under traditional Medicare. What value does some coverage for other possible services hold for you? Again, as Judy mentioned, Medicare Advantage plans sometimes will offer a limited dental coverage, for instance, a cleaning or two a year. They may have some hearing audiology coverage, some vision care coverage. They may offer some health clubs. These are fairly low-cost incentives that that the Medicare Advantage plans will often use in their programs that are not available under traditional Medicare. Are you comfortable checking regularly to ensure that providers and coverage requirements are not changing? Traditional Medicare is a very stable program. As I mentioned, everyone who is Medicare certified is available to a beneficiary who is in traditional Medicare. That is not true under Medicare Advantage plans. Their doctors and hospitals, therapists are oftentimes coming and going in and out of the Medicare Advantage plans. They have contracts that may be ending, and they're not always on the same cycle as the annual enrollment period, where you can change from one plan to another, or traditional Medicare to a plan, which happens between October 14th and December 7th every year. So that's important to see. If you are fine checking to make sure that your providers and your coverage requirements are not changing, as they often do in Medicare Advantage plans. But that's something else to consider. How do you feel about a medical director of a health plan potentially challenging your own doctor's determination that your care is reasonable and necessary? I mentioned this before. Again, it's something within managed care that the private insurance companies that are providing the benefits for individuals who are part of those networks, that's a big responsibility that they have to manage the care, is to challenge determinations from providers. And then the last thing really to consider is how do you weigh the cost? Because quite frankly, sometimes the Medicare Advantage plans can be more economical if you don't have assistance and you can't afford whatever. So it's whatever. I'm sorry, I shouldn't say whatever. You can't afford the Medicare supplement plan. Pardon me. And so it's just important. Everybody has to make their own choices, and that's a critical one. What are the costs of the various options that you have? What is the weight for you of the convenience of being able to see as many doctors as you want to see and not have to worry about whether they're in a network? And oftentimes we hear that Medicare Advantage plans have waits because they have a limited network and their doctors are limited in the plan, that individuals have to wait longer to get service than they might if they had more options as they do under traditional Medicare. And again, access to care. So weighing cost, convenience, and access to care. So those are, again, considerations, and we'll talk about that more later. So I'll turn the program back over to Judy, and we'll look at Medicare coverage, myths, or facts.
Thank you, Kathy. This section of the webinar, I think, is particularly important for people living with paralysis, because there's so much misinformation in the field about Medicare coverage for people who have conditions that are likely to continue for quite some time. It's important to remember that Medicare coverage, as I said earlier, is the same for people regardless of whether you qualify as a result of a substantial disability or having obtained age 65. By the same token, I want to make clear that there's no difference in coverage depending upon a person's diagnosis and needs for the health care. It shouldn't be that the person gets a different kind of benefit based on what their diagnosis is, why the person is paralyzed or has limitations. So speaking of that, here is one of the main myths we hear and have heard for decades. The myth is Medicare coverage is not available if the person is not going to improve. That's false. There is no duty to improve in order to qualify for the various Medicare benefits. Use of what we call an improvement standard is in fact not only inappropriate, but it is illegal. And that is certainly true in the care settings of the home health care arena, for outpatient therapy, and for skilled nursing facility care. In fact, one of the federal regulations specifically states, and this is the law, that restoration potential, another way of saying improvement, should not be the determining factor in determining whether Medicare coverage is available. So just as skilled nursing may be needed to improve a person's condition, or skilled therapy, physical, occupational therapy, or speech-language pathology may be necessary to improve a person's condition, so too, those services provided by qualified professionals may be necessary to maintain a person's condition or keep people from declining or slow deterioration. And if those skilled services are necessary, Medicare coverage should be equally available as if they're necessary to improve. That has been established most recently in a lawsuit that the Center for Medicare Advocacy brought in 2011 on behalf of 5 individuals and organizations, including the Multiple Sclerosis Society, the Parkinson's Action Network, now known as the Michael J. Fox Foundation, and Paralyzed Vets of America. So it's particularly important for you, if you're living or taking care of someone or advocating for someone who is living with paralysis, to know about this standard and this lawsuit. We settled the lawsuit on the premise that Medicare is available for skilled maintenance, nursing, and therapy, as I just said, equally as for skilled nursing or therapy to improve a person's condition. It is specifically said in the settlement of this lawsuit that those services are available in a nursing home, at home for home health care, and for therapy in an outpatient setting. And that includes physical therapy, occupational therapy, and speech-language pathology. If the person happens to be receiving services in an inpatient rehabilitation hospital, sometimes also often referred to as an inpatient rehab facility, some improvement may be required under the law, but only such as is necessary to have the person adjust to the practical experiences that he or she has now got to deal with due to a disability, or to deal with their own particular activities of daily living. You cannot be required to improve such that you are returned to base level before an accident, for example. So definitely question whether it's being properly applied. And again, here I want you to have the citation and the language for the CFR, which is the Code of Federal Regulations. This is right under the Medicare law. It needs to be attended to and not violated by anyone who's implementing the Medicare law. And it says that restoration potential is not the deciding factor in determining whether skilled care, meaning a nurse or a therapist, is required. Even if full recovery or medical improvement is not possible, it says, a patient may need skilled services to prevent further deterioration or preserve current capabilities. And that is so very important for people living with paralysis. I want to say a couple of things. One, it should be what's improvement that matters to this individual. So it may be that it's a modicum of improvement that's very relevant to your life and your quality of life. For example, we had an individual we represented who was able, with therapy, to keep her legs separated enough to keep a pillow between them. That was very important for her, and it was indeed improvement. And by the same token, preserving current capabilities or slowing deterioration can require skilled care, and that is also coverable under Medicare. Myth or fact? Medicare should not be denied based on a rule of thumb. Now, what do I mean by a rule of thumb? A rule of thumb would be Well, people who can shift from bed to chair on their own, have been taught to do that, no longer need occupational therapy. Or an individual who can now ambulate with assistance a certain amount of feet doesn't need physical therapy. That would be a rule of thumb. Or a person with paralysis does not benefit from and cannot get therapy. Those are what we would refer to as blanket rules or rules of thumb. Rules of thumb should not be used to deny Medicare coverage. That's true. Indeed, the opposite. An assessment of each individual's circumstance and need for care should be made in determining whether Medicare coverage and therefore access to care is available. So watch out for certain phrases that may actually be one of these illegal rules of thumb and that have been used to deny coverage. For example, an individual has plateaued or reached baseline. His care or her care is for a chronic and stable condition. And the famous one we've heard for so many years, and I've just told you is not legal, that it's maintenance therapy only. The latest example we're hearing is that the care is not complex or sophisticated, or just simply that the care is not skilled. These terms may be used and may not actually apply to the facts and circumstances of the individual's case, in which case they should be challenged. Myth or fact? If you're in a hospital bed for a day and overnight, you will be considered an inpatient for Medicare coverage. False. That might not be true. Shockingly, in this bizarre world of Medicare, sometimes you could be in a hospital bed receiving medical and nursing care, in fact, maybe getting tests and treatments, drugs, food, supplies, and in a room with someone who has been admitted as an inpatient. But, as I mentioned earlier, increasingly people are being considered outpatients and or in observation status, not inpatients under these circumstances. The reason this may matter is two basic reasons. One is this would be paid for under Medicare Part B, which means that there would be some costs that won't be covered that would be covered under Part A. For example, certain medications might not be covered under Part B. And if a person didn't opt into Part B, they wouldn't have coverage for the hospital stay at all. Perhaps most importantly, in order to get Medicare coverage for nursing home, skilled nursing facility care, a person needs to have 3 days of inpatient hospital level of care. If the person is considered an outpatient, none of the post-hospital nursing home care would be covered under Medicare. Myth or fact? You can get durable medical equipment, prostheses, orthotics, and supplies from any supplier that accepts Medicare. Regrettably, that's false. DME POS, durable medical equipment, prosthetics, orthotics, and supplies, must be obtained from a supplier who has a contract with Medicare to supply the particular equipment, prosthetic, or supply prescribed for the individual. So this is relatively new, and Kathy will talk a little bit more about it, but it's important to check with your prescribing provider, the therapist or the physician, and the supplier to confirm that Medicare will be available for the particular item that has been ordered for you. Myth or fact? If a home health care agency participates in Medicare, the agency must accept all beneficiaries who qualify for home health coverage. Again, regrettably in this case, the answer is no, this is false. Home health agencies can refuse to take on a patient. They aren't required under the law to take every patient who seeks services from them. And that is because the conditions of participation, the Medicare contracting rules, only apply after an agency has evaluated and accepted a beneficiary and decided to provide services. However, they cannot decide to provide services, to deny services to people based on discriminatory purpose, such as, of course, race, income, gender, or other illegal discriminatory characteristics. So let's talk about Medicare home health coverage and access to the home health benefit. This is so very important for people who are living with paralysis and are hoping to get most of their care in the home care setting. Regrettably, there is difficulty increasingly in accessing the full Medicare benefit to home care. Medicare home health coverage is available to people who are what's called or referred to as homebound and who need a skilled nursing or therapy service. Now, it's very important to emphasize homebound does not mean bedbound, nor does it mean, as we often say, that there's a no-fun rule. A person can go out of the house and does not have to be stuck in bed in order to qualify for home health care. Instead, what's necessary is that the person requires a taxing effort or requires assistance to leave home. And unfortunately, people who are living with paralysis are most likely homebound for the definition, to meet the definition under the Medicare home health coverage rule. And if you've been told otherwise, that would be a time you might want to check with us and really make sure that that isn't being misapplied. The covered services, if the person meets the qualifying threshold criteria, which have some other requirements as well, like the doctor has to order the care, the covered services would include skilled nursing, skilled therapies, which include physical therapy, occupational therapy, and speech-language pathology. And if a skilled nursing or therapy is provided, then what are known as dependent services, meaning that they depend on you getting a skilled service, will be covered. And that includes hands-on personal care provided by home health aides, help with the activities of daily living, bathing, dressing, helping getting your food set up, and maybe helping with eating. Those services are covered under the Medicare benefit as a home health aid service. Also, medical social services are provided and covered under the Medicare home health benefit. Now, there's a lot of misinformation in the field about the Medicare home health benefit, and coverage is often referred to as a short-term benefit. That's not true. It's not an acute care benefit. It's not for a short duration of time. And it's not only for people who are leaving the hospital, and it doesn't require a prior nursing home stay. Indeed, there are no legal duration of time or legal caps on coverage. It can go on so long as the person is meeting the coverage criteria. There's a doctor's order. The person is homebound, which, as you remember, doesn't mean bedbound. And the person needs skilled nursing or therapy. There's no duration of time limitation on that. And there's no legal cap on the amount of coverage, except that nursing and home health aides are generally going to be limited to a combined maximum of 35 hours per week, unless the individual is also receiving skilled therapy, in which case there might actually be even more aides available under the law. But this is very hard to receive in practice. I suspect we'll hear some of that during the question and answer period. So now, Kathy, perhaps you talk a little bit about a home health case study for someone living with paralysis.
Certainly. So we wanted to use an example to help illustrate the benefits in a real case scenario. So Mr. Park has paraplegia from an accident, and he has traditional Medicare coverage. His wife is his primary caregiver, but she's not available all the time. Mr. Park needs full-time assistance to move, for self-care, to maximize his level of function, to maintain his condition, and to continue to adapt to his physical limitations. Mr. Park leaves the house for health care appointments, church services, and occasional special celebrations, such as his granddaughter's graduation or the wedding of a close friend. So Mr. Park requires physical therapy for range of motion and to reduce rigidity. He needs occupational therapy to develop strategies for his activities of daily living and his changing needs. He needs occasional nursing to assess his skin and overall condition and to reevaluate his treatment plan. And he needs medical social services to help him and his wife to adapt to their changing circumstances. And he needs home health aides to care for his personal needs, and this is estimated to be about 30 hours a week. So Mr. Park contacts his doctor for an appointment to discuss home health services. It is determined by his physician that he meets all the qualifications for services under Medicare. So these are the qualifications that he's met. Mr. Park's home health services are reasonable and necessary. He meets the homebound definition. And as Judy said, that doesn't mean confined to the home as much as it means having a taxing difficulty leaving the home. He does not have a willing and able caregiver available to provide all the care he needs. His physician responsibilities in order for Mr. Park to obtain Medicare include the doctor certifying the need for 60 days of home health care, and that 60 days is called by Medicare an episode of care. So the certification happens every 60 days, but the renewal of the certification can continue. There's no, as Judy mentioned, no limit to the number of 60-day episodes that a person may have under Medicare. There's something called a face-to-face encounter. That means that the doctor has to actually go look at the doctor eyeball to eyeball and make sure that Mr. Park and the physician have clearly communicated about Mr. Park's home health care needs. That face-to-face encounter only has to happen with the initial certification, not on every recertification. The doctor must sign an order and a plan of care and recertify, again, as I mentioned, for subsequent 60-day episodes of care. So how do you locate a Medicare-certified home health agency? There's a couple of different ways to do it. Sometimes people hear about Medicare-certified home health agencies through referrals, through their providers. Sometimes they call 1-800-MEDICARE and ask them who are the Medicare-certified agencies, home health care agencies that serve my zip code. Or you can go to medicare.gov on the internet and search something called Home Health Compare. And in the Home Health Compare element of the medicare.gov website, you can put in your zip code, and in the search engine will provide you with the names of all Medicare certified home health agencies that serve the zip code that you live in. And it will also provide you with a list out of the 6 disciplines that Judy had mentioned, the 3 different therapies, the skilled nursing, home health aid, and medical social services, which of those different 6 disciplines those home health agencies provide. So that's how you locate a Medicare-certified home health agency. The services must be provided by or under arrangement with a Medicare home health agency. Oftentimes what we see is that an individual needs specialized equipment that's only available, for instance, in a hospital outpatient setting. And so in that circumstance, the home health agency would make arrangements with the hospital setting to use the appropriate equipment in that outpatient physical therapy department. And then the Medicare Home Health Agency would be responsible to pay for that treatment outside the home. Payment for non-Medicare covered services. And again, non-Medicare covered services would be available for instance, if you have additional insurance, and there would be payments that would be available for that. So I will pass it back to Judy now.
So as I mentioned at the beginning of this component, there is some problems people are facing actually getting the home health care that's been ordered for them by the physician. And that is the case even though the law hasn't changed. Access to home care, we're finding, is shrinking even when the coverage criteria are met. And we want you to know very definitively that we as lawyers are telling you that the coverage criteria have not been changed, have not been limited beyond what we've just told you. And we're hoping that with advocacy and knowledge and the materials we're providing, that you'll be able to get the home health coverage that the individual requires. CMS, the Medicare agency, that's the Centers for Medicare and Medicaid Services, is constantly describing the benefit incorrectly. As I said earlier, often they say it's a short-term acute care benefit when it's simply not. In fact, we've recently noted that a revised Medicare agency, CMS home health booklet, has the wrong information in it. It sounds like it's a short-term benefit, and it makes it sound, if you don't read carefully, that the home health aid that we told you earlier isn't covered under Medicare. Let me make clear that that's not true. It is true that Medicare covers home health aids for personal hands-on care, like I said earlier, and that means for the activities of daily living, bathing, dressing, helping to eat, and the like. It does not cover homemaker services or companion services, but those things can be part of what the home health aid is doing, but mostly it has to be for personal hands-on care. Even people who are clearly homebound, and that, as I said earlier, regrettably probably includes most people living with paralysis because it will take a taxing effort to get out of the home. And even if you're leaving the home, by the way, for medical services or for the religious services or for occasional social activities, you can still be homebound under the Medicare legal definition. And even if you're requiring skilled nursing or therapy, we are finding people erroneously denied, or people finding that they can get bare minimum of home health aid services. For example, we're hearing a lot of people for 1 to 3 hours a week and limited to the purpose of getting a bath. That is not correct, and we urge you to work against that, to use some of the information we're providing and advocate for what the doctor has ordered and what you actually need. We at the Center are working to ensure full legal coverage is available, and we will work with the Reid Foundation to help do so on your behalf. Kathy?
Thank you, Judy. So we want to take a look at the durable medical equipment, prosthetics, orthotics, and supplies benefit under Medicare. So durable medical equipment, or DME, is covered under Medicare Part B. It is defined as being durable. It can withstand repeated use. It has an expected lifetime of at least 3 years. Having said that, I want to stop for a second and just emphasize that if you have a change in your condition, and for instance, you need a different wheelchair than one that you might have received a year ago, it's important to have an item that's safe and effective for your use. So you want to make sure that if you need a different item than you currently have of durable medical equipment, that you work closely with your doctor to make sure that you can obtain what it is that you need in order to be safe and effective for your uses. The durable medical equipment must be used for a medical reason. And that seems like an odd thing to say, but for instance, it's not usually useful to someone who is not sick or injured. And an example I can give you is oftentimes people who have trouble breathing may need air conditioning because of the hot, humid weather in the summer. Medicare will not pay for an air conditioner because it could be useful to someone who is not sick or injured. So Medicare is looking for medical devices that is not used for the general, not useful to the general public. Must be used primarily in the home, not exclusively in the home, but primarily in the home. And this becomes an issue for people whose homes are institutions, skilled nursing facilities, and that is something that we've been trying to work with Medicare to change. But for right now, the item must be used primarily in the home. Home could be an assisted living facility, so there's a distinction between what's considered a skilled nursing facility, which is a significantly higher level of care. Durable medical equipment may be rented, purchased, or Medicare often gives people the ability to choose to rent or purchase. Rental is usually for 13 months, what's known as capped rental. Purchase of an item is an outright purchase. The choice to rent or purchase often turns on how long an individual may need the piece of durable equipment. It may turn on the individual's ability to pay the 20% copay. Oftentimes it's easier to do that on a rental basis. You end up paying about 5% more if you rent an item rather than purchase it. But there are different options for different items. Some items are just a purchase only or a rent only. So again, it's good to find out what your options are under that. So how do you obtain durable medical equipment generally? You get a prescription from the provider, and then you can seek the suppliers at Medicare.gov or 1-800-MEDICARE. Medicare.gov has a wonderful tool on the Internet. When you go to that website, you put in in the search engine, you'll look for durable medical equipment. You put in your zip code, and you can tell it exactly what you're looking for, what item that you want. It will help you to narrow the available suppliers for your zip code. So a good question you want to ask is, do the suppliers accept Medicare assignments? So those who accept Medicare assignment will accept the Medicare approved amount for the claim, and then for the item, and then you only have to, you will then pay the 20% co-payment, co-insurance. The important thing about the Medicare approved amount is if a supplier doesn't take Medicare assignment, then you may end up paying quite a bit more than the 20%. You want to ask, does the supplier carry the manufacturer and the model that you seek? And hopefully between a therapist and a doctor and whoever's given you the prescription for the item, they would have identified the manufacturer and model that you should be looking for. Does the supplier have good customer service? Oftentimes what we hear from people is they check on sites like Yelp. And if the supplier, if there's constant comments about how the customer service is terrible, then you want to avoid those suppliers. It seems rather an odd way to do it, but it can at least raise some alarm bells. And you want to know, when can the supplier deliver, set up, and teach you about the item? It raises big alarm bells if a supplier ever says they can't deliver, they can't set up, and they can't train you on the item, because those are requirements under Medicare, durable medical equipment, that be done by a supplier. And the last thing I just want to say on this, if you go to Medicare.gov and you put in your zip code and they give you a supplier that's 1,000 miles away, and you think, why would I ever go with that supplier? Oftentimes there's a hub where there's a supplier, and then they have a local customer service representative who may be phenomenal. So don't just out of hand reject a supplier because they're not listed as being local. It's worth a phone call.
Good tip. Thank you, Kathy. Now I'm going to talk about outpatient therapy and outpatient therapy caps. This is one of the few areas in Medicare where there is a dollar limit on the amount Medicare will pay for a particular service, and it demonstrates why that's not a very good idea from the beneficiary's point of view. In 2017, Medicare will pay up to $1,980 annually for the year, for the calendar year, for occupational therapy, and $1,980 for physical therapy and speech-language pathology combined. So that's a difference between these two sets of therapies. Occupational therapy is set off on its own, and then PT and speech-language pathology are combined with regard to looking at the cap. There's no good reason for that, and we were actually told by someone on the staff of a major senator involved with this law that it was probably just something that was done to save money, but it is combined. So that can be a problem for the many people who need both physical therapy and speech-language pathology services. Now, there is what's known as an exceptions process in order to obtain more than $1,980 annually for these sets of services. You can request an appeal, in this case it's known as an exception, to allow for more payment. The first level of appeal of an exception will be available to you to grant up to $3,700 for the year. And indeed, after that, there is also an ability to get a further exception, a medical review, to seek services beyond $3,700 a year. If you are seeking an exception, which certainly try for, if the doctor and your therapist and you know that you need these services on an ongoing basis, which is very likely, then get the doctor to state why. If you have a physiatrist, a doctor specializing in therapy and rehabilitation services, get that doctor to write why. And the same for the physical, occupational, and or speech-language pathologist. These services are so important, we know, for people living with paralysis to maintain your condition, to perhaps slow decline, and maybe make slow progress. And we don't want the Medicare rules to be inappropriately applied so as to interfere with necessary therapy. This therapy is paid for under Medicare Part B. And if an individual is residing in a skilled nursing facility and it's not covered under Medicare, that is, the nursing home care is not covered under Medicare, the individual can, we want you to know, get therapy provided in this way under Medicare Part B. And those therapies will be then subject to this cap. This can be important to continue therapies for people who either can't get Medicare Part A coverage for the nursing home care as a whole, or who've received, have exhausted, have used up their Medicare nursing home, skilled nursing facility benefit. Now, we are working with others, including the Christopher and Dana Reid Foundation, to seek a repeal of the therapy caps I just told you about in Congress. This is a law. We've been working to repeal the law entirely and or to adjust it. One idea is to at least separate the physical therapy and speech-language pathology, which, as I just told you, are capped together. And we've learned that there wasn't any good medical reason for that, which seemed pretty apparent. There have been suggestions that that the law, instead of being fully repealed in order to save money, that they put in a prior authorization instead. But we're concerned that requiring prior authorization for these kinds of outpatient therapies would actually create more problems than it solves, because our experience with prior authorization is that it often leads to earlier denials of therapy rather than to an opening a gate for therapy beyond the cap. But just let it be said that we know these caps are a problem, and we are working and will continue to work to try and repeal the therapy cap. Kathy, you want to talk further about appeals?
Thank you, Judy. I know we're getting into our question and answer period, so I'm going to make this fairly quick. I just most importantly want to let you know that any time you are threatened with a denial of services or termination of services by Medicare, you will be given a notice. And the information that you need in order to take the steps to appeal the denial or termination of services will be on that notice. So there are two different types of appeal systems. There's the expedited appeal, where you can request an appeal if you disagree with the provider's decision to discharge or terminate services. You want to make sure if it involves an inappropriate discharge from the hospital, you want to call the quality improvement organization that's noted on the discharge appeal notice information that you get in your notice. You want to call before your scheduled discharge. If it's an inappropriate termination of Medicare-covered services from a skilled nursing facility, a home health services, or a rehab facility or hospice services, you have to call the Quality Improvement Organization. Again, the number will be on the notice of denied services. You want to call before noon of the day following the receipt of the notice. And oftentimes that will delay the termination of services. So expedited appeals. And then there are standard appeals. And again, there's any number of levels on a standard appeal, and it will be the information that you will get on the notification spells out the next steps and your appeal rights in each one of these levels. So let this be a resource for you. There's no reason to remember all of this, but if you ever are in a situation where you feel that you need to appeal an improper denial by Medicare, you have this information to look back on.
So now we'd be happy to take questions and discuss with you this information and other concerns you have regarding Medicare and getting the coverage for medical and rehab services that you need.
Thank you. If you'd like to ask a question, please signal by pressing star 1 on your telephone keypad. If you're using a speakerphone, please make sure your mute function is turned off to allow your signal to reach our equipment. A voice prompt on the phone line will indicate when your line is open. Please state your name before posing your question. Again, press star 1 to ask a question, and we'll pause for just a moment to allow everyone an opportunity to signal for questions. And we will take our first question.
Yeah, hi, my name is Derek O'Brien. I missed it. What did you say? How long do I have until in between getting a wheelchair to another wheelchair, how long time period do I have?
So it depends on whether or not the wheelchair that you have is, age is something. Typically, an individual would be able to keep a wheelchair for 5 years, and then it becomes time to get another wheelchair. If in the meantime the wheelchair is not working properly for you, Medicare will pay for repairs. If you're looking for a different model and it's necessary for you to have a different model in order for it to be more safe and more effective than the current wheelchair that you have, then you'd have to have your doctor and your therapist make a case to defend that need prior to the expiration of a 5-year time period with your current wheelchair.
Okay, so it's 5 years.
Essentially, yeah.
All right, perfect. Thank you so much.
And I will say, because it's a constant irritant to me, that Medicare, if it's a purchase, that's one thing. If Medicare is renting an item, they don't consider the 5 years to be the full life of the item. So say, for instance, somebody rented a wheelchair for 3 years, and then it goes back into the rental pool, and somebody then gets the wheelchair. They don't get like 2 years and then they get a new wheelchair. They get it for 5 years, unless it's completely non-repairable. So the wheelchair, if it's rented, just keeps going back in the rental pool. And I always worry that there is safety and effective issues that have to do with that. But that's really a call of the suppliers and how they're able to rehab them or not.
I usually own mine outright. I never rent, really.
Okay.
I see a question that's been asked about getting home care in an assisted living, and I want to answer that because we didn't discuss it. And while a nursing home, you generally would not get home care as a patient in a nursing home. A resident in an assisted living facility, that you can get home care there, Medicare home care coverage. And the question in particular says, can you get assistance in the assisted living facility to get out of bed, on the toilet, and in the shower? So that also raises a sub-point that I want to reiterate. You need a skilled service, a nurse or a therapist, in order to have Medicare pay for the home health aid. And it would be a home health aid in Medicare that would pay for those, for that help with toileting, showering, and the like. So just to reiterate, in summary, you can get Medicare home care coverage in an assisted living facility, but the home care benefit under Medicare requires a nurse or a therapist in order to get home health aid services. Okay, so now is there another oral question that someone has?
We'll go to our next question.
Yes, my question is, are the PowerPoint slides available?
Certainly from the center, and perhaps someone from the Christopher and Dana Reid Foundation would like to answer that. We do have a couple of typed questions also about whether the slides are available, how people can print them, and if this webinar is being recorded. And I'll just say the answer will be yes. I'm not sure exactly how that will work, but we will definitely be able to get the slides have all been provided to the Christopher and Dana Reid Foundation. If you're on the webinar, I'm sure either we or the foundation will be able to tell you after the webinar how to print them out.
Hi, this is Julie from the Christopher and Dana Reid Foundation. I did let everybody know in the chat box as well that they will, all the participants will receive a follow-up email with the assets attached. So thank you.
Thank you very much.
Great, thanks.
So I'll answer a question. I'm sorry if I'm taking anything out of context or out of sequence here, but there's a question about what is the difference between a Medicare Advantage plan and a Medicare Supplement plan. So a Medicare Supplement plan, I often say, fits like a glove over traditional Medicare. And what I mean by that is traditional Medicare has co-payments, co-insurance, deductibles, and you can purchase a Medicare Supplement plan to supplement traditional Medicare, and that will help to pay for those out-of-pocket costs that people typically have with deductibles and co-insurance and co-payments. So a Medicare Supplement plan supplements Parts A and B of Medicare, traditional Medicare, or sometimes called original Medicare. A Medicare Advantage plan is a completely alternative choice to traditional Medicare. So you choose either to receive Medicare Part A and B, or you choose to receive a Medicare Advantage plan, Medicare Part C. Hopefully that explains it.
Is there another question from participants, or shall we answer one that's been typed out?
We do have another question in the queue.
Okay, and then we'll do a typed one next.
Yes, hi. This is Bob Rubisky. Can you hear me?
Yes, Bob.
Okay. I just wrote on the chat, my son's 20 years old, paralyzed at Kessler. We've applied for Social Security. He got the disability insurance approved. We were told that he's automatically enrolled into Medicaid, but we've gotten no confirmation of that at all, and was curious as to what the next steps I should take with this.
Yeah. So just to be clear, you said he was enrolled automatically in Medicaid.
Not Medicare.
Right.
Medicaid.
Which makes sense because he would, if he's getting Social Security disability insurance, he would have to wait for 2 years. So I'm going to give everybody a tip that's really important. You may all know about it, but there's something in every state called a SHIP, a State Health Insurance Program. These folks are trained counselors. It's a free service, and if you go to the internet and ask for the SHIP for whatever state you reside in, you'll get like an 800 number. These are individuals who, again, are Medicare experts, and they will help not only will they help to answer that question about the specific Medicaid program in your state, because Medicaid is a state program unique to every state, but they will also help every individual to determine if there's any access to assistance, payment assistance under Medicare. There are some very generous states that will give you assistance in covering deductibles and coinsurance and copays. So the state health insurance program, the SHIP for every state, is a really great resource.
Okay, that's great. I have a follow-up question.
And to remind us that there is a SHIP website. So if you go to SHIP TA, Technical Assistance, it stands for SHIPTAcenter.org.
Right.
Okay, there's a question here also about improvement in the inpatient rehab hospital arena as opposed to in a nursing home or therapy in an outpatient setting or at home. Because of the some unfortunate differences in the law, we were unable to succeed in getting improvement completely out for people in inpatient rehab hospitals. However, what I want to make clear is that the level of improvement that can be required is not to the prior level of function, is not to demonstrate that the individual can regain full function, but rather that the person can better adapt to his or her new or ongoing level of paralysis or disability, can adapt to that, and or can improve in his or her ability to manage in a way that is of practical value to the person. These things are available on our website. There's a lot of material about GMO and improvement. And you see the website is at the bottom of every slide, MedicareAdvocacy.org. So I'm hoping that what we were able to get into the GMO settlement with regard to care in an inpatient rehab facility will still mean an inpatient rehab hospital. They're the same thing. That very often people living with paralysis can get Medicare coverage because the amount of improvement that is allowed to be looked for is really what's of practical value to the individual.
Okay, I'm going to go back to the very first question that was asked of us, and it's a terrific question. It's from Tom, and he says his son is 23 and about to join Medicare. Do most people like him get a Medigap policy? Okay, so when you become eligible for Medicare, every state, again, may be different, but most states have a 6-month window when you first join Medicare, and it's called guaranteed issue. And guaranteed issue means that it doesn't matter what your condition is, that you can't be discriminated against. You have to be charged the same amount of money for a Medigap policy as everyone else. So it's important if you're considering making a choice when you become eligible for Medicare, to think long and hard about whether or not you want traditional Medicare based on the questions that I had set out earlier. And then sign up for a Medigap policy because once you're in under the guarantee issue, then they will raise everybody's rates, but you won't be treated differently. Now, after the 6-month guaranteed issue, unfortunately, and we hear this constantly, the premiums can really shoot up for someone who is considered to be disabled through Social Security. So it's a great question, and thank you for asking it.
Is there another question from somebody who's raised their hand? Otherwise, we'll go to another written, typed-in question.
And there are no questions over the phone line at this time. If you would like to ask a question, please signal by pressing star 1.
Okay, we have a question from Rachel here. And how does one, Rochelle. How does one get a CHHA to continue home health care to maintain one's functioning? Most CHHAs refuse to do that.
Certified Home Health Agencies, also known as CHAs in some part of the country. Right. Well, this is a circumstance that relates to the point we were making, Kathy, with regard to the difficulty we're finding in not only getting home care, but in retaining the home care that someone is qualified for. Home health care, as I spoke earlier, is not limited by law to any particular duration of time. And if the individual still needs skilled nursing or therapy to maintain functioning, that should be coverable under Medicare. So what I would say is that the therapist, let's hypothetically, let's say it's physical therapy that needs to continue. Then the therapist hopefully will, and the doctor, make the medical and rehab case, therapeutic case, for why this is necessary, and not do what we often hear, which is that they decide that based on what they understand Medicare rules to be, that they just can't continue to provide it. We're telling you as lawyers who focus on Medicare and the attorneys who brought the JIMO suit, that Medicare coverage is available if it's necessary to provide ongoing therapy for the therapy to be safe and effective to maintain the person's condition. So if without the therapy the person would deteriorate or decline, then the therapy should be able to be continued. And it is not true that it needs to end and the person needs to show that they're going to decline. And we hear that all too often in order for Medicare coverage to be continued. Just as an aside, I'll tell you that happened to my own mother, and Kathy had to do an appeal for her, and she did decline without the therapy. That is not legally appropriate.
Okay, here's a question from Peg, and it's about durable medical equipment. Can I insist on something that may be more expensive if it is easier for me to perform certain tasks on my own? Or can Medicare insist that I accept a cheaper but less useful device? Well, I think part of what Medicare looks at, again, I always use the word safe and effective, because if effective can be tied to safety. And if you're looking for something that has every bell and whistle, but you can't necessarily tie it back to the safety piece, which is really big, then Medicare may push back. I have a piece of advice on that, which is encourage your doctor, your therapist, your providers, the people that are prescribing the item to be as demonstrable as possible with explaining why you need certain accessories or certain items or a particular piece of DME. Especially if you're looking for something that makes your task easier, you can always tie that back to the fact that things that are difficult for an individual is taxing on an individual. I would also say it's really good to talk to suppliers who know the ins and outs of what works with Medicare and what doesn't work with Medicare. There are very savvy suppliers out there that would love to give you everything that you need to make your life easier. And they know how to do it. They know how to submit the documentation to Medicare in such a way that it supports what you're looking for. So again, do the best you can for the documentation, but also take the advice of either others who have gotten, I'm sure the Christopher and Dana Reid Foundation have a tremendous amount of resources to share with you about how individuals can get certain pieces of equipment, and also the suppliers in the community.
Yeah, and I just want to add, so it doesn't sound like we're saying, suggesting, and Kathy's certainly not, that you make up a reason why this thing is important. It is important, and it's necessary. And I think people, I've heard way too often Medicare decision makers who just don't understand what's necessary for persons living with paralysis and other difficult medical conditions, how difficult it is. We've had people, I know there's one or two on the call with living with ALS, and receiving decisions that just make no sense in light of what their life is actually like, what their medical needs are actually like, what their rehab needs are actually like. So I think, as Kathy is suggesting, get the doctor and the rehab specialists and the suppliers to write document why it is necessary that you receive that particular service or supply to meet your needs.
Right, and these are terrific questions, by the way. Thank you. Yeah. Jill asks, are Medicare-approved home health agencies limiting services to avoid scrutiny or audits? And the answer is yes. And we've worked with a number of home health agencies that have called us that have provided home health services to individuals for years. And for those people who are getting home health services and have been getting them for years, they do raise fraud triggers for Medicare. And so there's a certain amount of justification that seems to have to happen. It's completely unfair, and it's one of the things that the Center for Medicare Advocacy is fighting against. Home health agencies, particularly, and we find it's a lot of nonprofit home health agencies that are just trying to do the right thing and serve the people who need to be served. They should not feel that they have a fraud trigger hanging over their head because they're going out of their way to provide services that are covered under the law.
Yeah, speaking also about home health care, today we are issuing the second in a series of issue briefs about these problems with home health care. And I know that some of the leadership at the Reid Foundation gets our weekly alerts, and I hope that they can make that available to people on the line today, which give you all the legal citations about how to advocate for yourselves or for people you're helping with regard to access to home care.
Right, and everyone on the line can go sign up for our alerts at that MedicareAdvocacy.org website.
Yeah, they come out generally every Wednesday, and they're no charge for that.
And we do have another question.
I can take one more question. Yes.
All right, I will I will open the line for the question in the queue at this time.
Hi, I have a question. What do you classify as an inappropriate discharge from a hospital, especially for nursing home residents?
So, do you mean an individual who's, when they leave the hospital, is going to go back to the nursing home?
Yes, and they're discharged early, but they don't feel their care is taken care of appropriately in the hospital. Is that what Medicare designates as inappropriate?
Well, we need to know the facts of the case, but hopefully the physician does have the ability to contest a discharge. So does the individual.
Yeah. So anything is inappropriate where you feel like it's not safe for me to go home, and there's more that needs to be done to diagnose my issues or to stabilize me. So inappropriate discharge can be a broad range of particularly if the doctor agrees that an individual should stay longer in the hospital. And that's why there is this process by which you can stay in the hospital and you can continue to get hospital level care until such time as there is a review through this expedited process. So the expedited process happens. You challenge that and say, I'm still in the hospital. I don't think I should be discharged. My doctor agrees with me. And then a review happens. So that's typically how that works.
Okay, so Medicare would tell the hospital that they're not paying for it, but the doctor still feels that their patient should stay in the hospital, correct?
Yes, if the doctor agrees with the patient that it's not safe and effective for the patient to be leaving the hospital yet, and that the patient still needs care in the hospital, then as a slide that we showed earlier demonstrates, you would say that you want to contest the discharge. Usually it'll be within 24 hours that they'll make a decision, and it's going to be very helpful to have the doctor speak up in favor of the person remaining in the hospital.
Right, and again, as we mentioned, rarely under traditional Medicare are the Medicare contractors going to override the decision of the doctor. If the doctor has justified the individual's continued stay at a hospital level of care, if you're dealing with a Medicare Advantage plan, the Utilization Review Committee or the medical director of the Medicare Advantage plan would have an opportunity to challenge the treating doctor's decision to have a patient continue in the hospital.
Thank you very much. I appreciate that.
Mm-hmm.
Sure.
Yeah, well, I think we've reached the end of our time and answered many of the questions. So we'll thank the Christopher and Dana Reid Foundation so much for allowing us to speak with you today, and hope that this information has been of value. I want to remind you that the Center for Medicare Advocacy has a great deal of information available to you at medicareadvocacy.org. You can sign up for our weekly alerts there and find information that will be particularly, I think, important for people living with paralysis, because so much of our work does and has always focused on people who need care over the long term. And one of our top two priorities are to make sure that people aren't inappropriately denied coverage because they need services to maintain or slow decline, and are required erroneously to improve, or improvement is erroneously defined, and also to make sure that people get the home care they need and these other services that we've been talking about. So we thank you all. We thank the Christopher and Dana Reid Foundation for making this webinar possible, and invite you to go to medicareadvocacy.org to continue learning about your rights under the Medicare program. Thank you very much.
This concludes today's call. Thank you for your participation. You may now disconnect.